think about this, you guys. How many kids do you see, or adults do you see, that have arches that are deficient? And by arches, I mean the maxilla and the mandible. Okay? And the answer is about 80%. About 80%. And the reasons are because of what Weston A. Price and those guys discovered, is that people on traditional diets had fully developed arches. People on non-traditional diets have deficient arches. So he said, okay, so here's my question to you practitioners out there. If 80% of your patients have deficient arches, then why in the world would you take out 4 perfectly good bicuspid teeth and constrict it down even further? And I'm sitting in the back and I'm next to this guy and I'm going, what a great question. He goes, that's what you guys have been taught to do. And he says, but there's a schism in the orthodontic camp. There's what we call the 4 on the floor ortho guys, and then there's the functional ortho guys. So the functional route uses expansion because we thank you, dear. Oh, thanks, Buzz. We use growth plates. We use the growth plates, and I'll show you some slides on that here in just a minute. We use the growth plates to kind of develop the arches out. And Janet, you know on Jenna how we did this. So instead of taking perfectly good teeth out and constricting everything down, and if you want to see what I'm talking about, who's the prince in England? Is it William, and who's his brother? Harry. Look at those 2 kids. They've had 4 on the floor bicuspid orthodontics, and their arch form is very narrow. When they smile, they've got a wide face, but they've got this really tiny little arch form. And I used to be able to sit on airplanes and look at people and go, that guy had his premolars taken out. I could just tell, because what happens is it grows the nose longer. Anyway, so I'm going to give you about we're going to catch up here and be on time. So functional ortho has the potential to fix the face, improve the functional conditions, promote a more favorable jaw relationship, and guide the development of the dentition, and improve the position of misaligned teeth. Now this one, you're gonna love me for this. It's got a lot of pictures in it. Okay. Benefits of functional jaw orthopedics: well-developed arches, a full media smile. Everybody wants a Julia Roberts media smile, right? And who's the one with the big lips? They want to, she's kind of messed up our whole thing about lips, but yeah, Angelina. Great looking profile. Proper nose-lip relationship, that's a big deal. Properly placed condyles. Pain-free joints. Very minimal relapse because we've influenced the growth plates. Okay, theories and philosophies. Okay, I told you about the 4 on the floor, actually 8, because once you take the bicuspids out, now you got to take the wisdom teeth out. And this is a European orthodontic approach, and in Europe they do a lot of second molar extractions, which we just did on Jenna. And so instead of taking the third molars or the bicuspids, you just take the second molars out and then you distalize the arch form. I'll show you this in a minute. So here's the difference. Okay? Here's before and here's after. Look at the difference in the width of his smile. Why consider it? Because you'll get rid of headaches. You'll fix TMJ issues, and you will prevent temporomandibular joint disorders. Breathing problems, because it's all about the airway. It's all about 2 things: the muscle and the airway. The muscles. We'll fix underdeveloped arches, crowding and retrusion, and then orthoclass bites. We say class 1 is like this, class 2 is like this, class 3 is like your Chihuahua. Okay, underbite. Okay, and self-esteem. I mean, you know how kids get picked on today for every little thing. So you don't want to send them out there in the world or to school with a messed up bite. I mean, it's half of their face. Okay, so here's the orthodontic relationships: overbite, overjet. So to give you an example: overbite, overjet. Okay, see that? So we have incisor retrusion and blocked out cuspids. That's a perfect case for orthodontic expansion on the right. What are functional conditions? People say, well, when do you start this? You know, the old way was, well, let's wait. Okay, basically this is it. Let's wait till all the teeth come in. So when you hear your orthodontist say, let's wait till all the teeth come in and then we'll do something. What they're saying is this. Let's wait till all your teeth come in and they're all screwed up. We'll take out 4 perfectly good teeth and we'll crowd down the bite. And we'll screw up the TM joints and we'll make the nose look bigger. How's that sound? And you're like, what? So the functional conditions are crossbite, like this. And when you have a crossbite, if you have a functional crossbite, now your jaw is growing this way. Okay? And so that's a developmental problem. Mouth breathing, thumb sucking, overbite, deep bite, overjet, buck teeth, end to end. I'll show you some of these. Retruded chin. Airway constrictions. Boy, if you have an airway constriction, that's a big deal. Temporomandibular joint problems, snoring, restricted airway, blah, blah, blah. So here's a functional correction. Here's an orthodontic expander, or we say ortho. This is actually orthopedics. You're moving bone around. Okay? So think of it this way. Phase 1 orthopedics or orthodontics is the orthopedic phase of orthodontics. Or the orthodontic phase of orthodontics, phase 2, is straightening the teeth out. Just like boxcars on a railroad track. We put a wire on and we move them around. Okay? And we line them up. You can't do that with functional appliances. But what you can do on the left is see how that form there is just kind of very narrow on the upper and the lower. And then you put the expander in, you expand it out. Now what we're doing is we're putting pressure on the growth plates. And we're actually expanding, growing new bone. Okay? And then on the right side, or on the left side, but on the right side of the left side, does that make sense? You can see how it's expanded out. So here's this little girl, and here's what it looks like. It's all about the airway. The airway rule. If you're not breathing, nothing much matters. Right? But the muscles really rule, because the muscles are what control the growth. So mouth breathing and arch development are well connected. It causes improper facial development. Doliocephalic, long face, like, you know, the horse that walked into the bar. You know, why the long face? Yeah, right. Maxillary arch narrows. That's when I say maxillary, I'm talking about your upper arch. Mandibular is a lower arch. The mandible falls down and forward. Okay? TMJ compression, you have compression of the temporomandibular joint, which can cause headaches, by the way. And so for a lot of people don't realize, and physicians and dentists don't realize, that if you're having temporomandibular headaches and they start right here, okay, in the temporal region, and they go into the, you know, between your nose and between your eyebrows, or they can be occipital, and you have them in the morning. Because your jaw has been back, it puts compression on the TM joint right here, and there's a bunch of nerves and blood vessels and lymphatics that run back there and cause headaches. And so you go to your physician and they say, well, you know, give you some Imitrex or whatever else, and I don't know what to do. But what we can do is we can have some very simple tests, and we can determine whether it's a TMJ headache within days, and then put you into a splint and get rid of the headaches, if they're TMJ related. And there are components, because there's so much facial development that's not correct, or people have been in traumatic accidents, etc. Football players, you know. So TMJ compression is a big deal. And airway constriction can lead to OSA, obstructive sleep apnea, which can lead to strokes and heart attacks. And obesity, and OSA can lead to obesity, and obesity can lead to OSA. So you have a real cardiovascular issues with this kind of a situation. Orthodontic problems, nasal and tonsillar and adenoid problems. I know of a few ENT people who will actually take out adenoid tissue and tonsils if they're class 4, because they restrict airway growth, and they restrict the growth of the arches. You must correct these issues early on. Waiting is not a good idea. Okay? We call that supervised neglect. Well, we'll just watch it. Really? What are we going to watch it do? Well, we'll just watch it get worse. And then what are you going to do, Doc? Well, we'll figure it out then. Instead of going in early, treating it early, you get in, you get out. Okay, so if there's a crosspipe problem, if there's a thumb sucking problem, if there's a real arch deficiency problem or an airway problem, you get in, you fix it, you get out, and then you let them grow. So you're helping influence. We use the genetics to help them to grow. Now here's what I call when a kid walks through the room and 5 minutes later his chin comes through. That's a class 2. Okay, and so for any of you practitioners out there who your patients are saying, I get these headaches all the time, and they're not cyclical. They're not cycling, and they're mostly when I wake up, or my muscles are sore here. Look at the bite. If the bite looks like that on the left, there's a 90% chance you're dealing with a TM joint or a TMD related headache. And so if that's you, come see us, or go see a good, functional orthodontist. Mandibular positioning, the lower jaw positioning. Look at how her chin is kind of sucked in on the left side, and there's a mental fold. And I'm sorry I don't have a laser pointer here, but you see that little crease below her lip. In the next picture, we've done the arch width and arch length analysis, and we've done the appliance therapy, and there she is. Look at the difference. Now, do you think that affects self-esteem? Yeah. So, ortho terminology. We do a cephalometric analysis. That's X-ray stuff. We determine, where the angles are and all that. That's really boring. We do an arch width analysis. We analyze how much they need to grow. Okay? And we can do that on an X-ray, and we can, that should say arch width, arch length analysis. We analyze the width and then the length. How much space do we need to gain? Orthodontia is all about how much space you need. There's a lot of ways to gain space. You can pull teeth. You can do IPR. You can use expanders. You can do crowns. You can do veneers. You can do all kinds of stuff to kind of gain space. But in the final analysis, it's all about arch development. Okay. There's an ideal smile. Look at the lips. Look at the class occlusion. Look at the bite. So what we look for is a stable bite, stable occlusion. Because an unstable occlusion, what we call a malocclusion, can cause headaches. You've got a lot of structures passing through the temporomandibular joint region, and that can cause lymphatic issues, it can cause venous return issues, arterial issues, and headaches, nerve issues, and growth issues. So we're looking for lip projection, overbite, overjet, a wide median smile, healthy joints, and open airways. That's what we're looking for. Techniques. Expansion orthopedics, clear correct. Now there's all these digitized ways of doing this. They're called CADCAM technology. We'll take impressions on you, we'll send the models in, and depending on how much space you need, we'll determine, they'll make these trays on a computer, and each tray turns it to, a tenth of a millimeter, or a quarter of a millimeter, or whatever, and through a series of trays, you don't have to go through the brackets again. The reason ClearCorrect became so popular was because there was so much relapse on the 4 and the 4 bicuspid ortho, because that's not stable. And most of those people have jaw clicking, jaw popping, and headaches. We see it every day. Easy Align appliances, that's another CAD-CAM technique. Invisalign. Those three are the same. ClearCorrect, Easy Align, and Invisalign. And then we get into arch wires. Stainless steel versus night-tie single wires. These are the single wires, and now they're giving courses on doing ortho with a single wire. I'm not sure how they're doing that. We use a set of 3 wires. But this is all NASA technology. These nickel titanium wires. Now, don't react to the nickel thing, because they're not on there for that long, and there's very little in there. And they're away from the teeth. Because people say to me, well, they have nickel in them, right? I go, yeah, but do you want straight teeth, or do you not want straight teeth? A lot of this stuff, there are no perfect dental materials in the world, folks. There are some that are a lot worse than others. But you got to look at the end, look at the, not the mean so much, but the end. So this has all come from NASA technology. Now they can put on and they're all heat-treated wires. So they're like this, they're rigid, and then when they get into your mouth, when we put them in your mouth and they're cold, they'll look like a little wet noodle when we put them in. But the heat activation in your mouth will straighten the wire out. And so as the wire straightens, the teeth just go along for the ride, as long as you can keep the brackets on. The bracket types, we have metal and clear, very small. Back in the day, they had these big bands that went around your teeth, and that was just not a good idea. Retention. So there's what Invisalign looks like. Okay, there's the trays. There's the clear braces versus the brackets. It just kind of depends on what your situation is, how much we're trying to move teeth. If we're trying to change a bite and try to bring your jaw forward, then we got to go to the right side. If we're just looking to kind of do a class 1, situation where we're just doing it mostly for aesthetics, then we'll go with the left side. And there's a palatal expander. That line on the right side, that's called your mid-palatal suture. And there's 2 other ones called the prefrontal sutures that go this way and this way. So we can take, now that's a fixed appliance. Mostly we use removable appliances, but some moms come in and say, I know Johnny's not going to wear these, stick them in there so that they stay. And we're like, okay. This is an ideal case for expansion right here, okay? We can take that and we can make that look pretty good. Okay, so there was an oral surgeon named Harold Gelb, and he developed this thing called the Gelb 4-7 position, which is what we call the physiologic pain-free position. Now, this is the temporomandibular joint area, okay? That you see where the ear is, and then that upper squiggly line is your temporal bone. That's the bottom of your brain. That's where your brain rests, okay? Or is next to it. Then that where it says 4-7, that's what is called the condyle. That's the end of your mandible. So if you go out to the right side, that's where your teeth would be. So he designed a grid that puts the condyle in the pain-free position. That's a physiologic pain-free position. And you can see that it has enough space. There's space in there that allows the joint to operate smoothly. When you get all that clicking, that's your disc popping off and on, and I think I have a slide here to show that. So we call this the Gelb 4-7 position, which we say is a physiologically pain-free position. Okay, and that's huge. There's a class 2. Here's another case that we show. You've got that little mental chin thing going on, and there's what her chin looks like after you advance her mandible. Now, some clinicians will say, you can't move the mandible. And so this clinician that I first started telling you that I went to hear that seminar the first time, he says, you've been taught wrong. He says, well, I'm going to show you 150 cases today of cases that didn't work, and you can tell me if this works or not. And so after I saw that, I went back and I started working on patients in Minnesota, and I go, this works great. I don't know where these guys get the idea that this doesn't work. But that's where the schism in the orthodontic camp is. Do you do ortho expansion or do you do extraction in braces? And the answer is, if you have a bimaxillary protrusion like this, then you probably want to do extractions. There are times when you do extractions, but about 98% of the time you can just expand out if you start early enough. But see, they don't start early. They say, well, let's just wait till all their teeth are in, then we'll pull 4 perfectly good teeth, and we'll just retract down the mandible and the maxilla. So why should I go through this? To avoid surgery. The other thing you hear is, well, they're going to have to break the jaw. You're not breaking my jaw, I mean, there are some cases where you might have to do some surgery. But I'm telling you, if you've seen that surgery done, it is ugly. And I wouldn't even put a kid I didn't like through it if I didn't have to. Not that there's too many of those. To correct speech pathology. If your tongue doesn't have enough room to go to, you're going to have speech problems. So I was working with this friend of mine named Bob. Bob Kapsner was his name, and he was a speech pathologist. And when I first got into this, he was working with these kids, And I started expanding their upper arches. And he called me up and said, Thom, what are you doing? He said, these kids can, all of a sudden they can talk. I go, well, we're expanding out their jaws. He's going, well, the tongue, they don't have the problems that they used to have. I said, well, there you go. So it's great for that. Crossbite correction. So if you have a crossbite, if your teeth are like this, you really want to correct that. Because your jaw, this side will grow longer than this side. And that'll cause all kinds of TMD issues. Maxillary and mandibular arch deficiencies. And like I said, about 80% of people have this. Why? Because I believe Weston Price was right. Traditional diets were the way to go. You start constricting the diets, you start taking out the nutrients, you start messing with growth factors that, 20 years ago we probably didn't even know about. But we do now. Ortho phase 1 arch development. Because a lot of the times, you don't even have to do braces and brackets. You do the arch expansion. Think about it, folks. If you expand out the arches, because we do this before the permanent teeth come in. This is the way we figure this out is we do a panoramic film. We'll send it to our orthodontic lab. They'll measure the size of the teeth. They'll say, you need this much space. We design an appliance that creates that much space. Then by the time the teeth come in, guess what happens? They line up straight. Duh. And it works. It just really works. So you can avoid braces some of the time. Or at least you can get to the point where you say, maybe I don't need them. Or you can make an informed decision. Anterior open bites. That's a tougher case. That's where your teeth aren't coming together. That's a little tougher. Underbite corrections. When you expand out the jaws, you can increase. You can fix the underbite corrections. Okay. So it shortens the phase 2 correction. So here's a case. Here's a class 1 crowded. Here's where we start. Now, on the left, we've actually got an appliance inside of that. We can do it at the same time. We can do the appliances inside and then put the brackets on. There you go, 15 months later. Now, here's a lady with a class 3. Look at that chin on the left. Okay, now that probably is a surgical case. Hey, Evelyn. I showed a picture of you earlier, dear. So there's a class 3 case. That's your traditional underbite case. Okay, now you have to determine whether she's got a prefrontal maxillary problem or not. And that could very well be a surgical case. So I'm not saying that there's not cases for surgery, but I'm just saying there are very few. So here's an ortho correction in progress. We've got wires. We've got an upper appliance expanding out. So it gets to be kind of a mess, a complicated mess as we're doing it. And here's another way we gain space. This is called IPR, interproximal reduction. Instead of pulling 4 perfectly good teeth, what you can do is take a little bit off of each one. We call this interproximal reduction. Okay. And so we call it slenderizing. I had one lady, and she goes, well, you didn't tell me you were going to cut my teeth. I said, well, we showed you that we were going to kind of, take some of the enamel off. And she didn't want to do that. And I'm saying, okay, well, then we won't do that. And then we can distalize the molars with these appliances. So you see that tooth on the right side, that's a cuspid coming through there? See how that we call that a blocked out cuspid. So that appliance on the right side is pushing everything back. Okay, so you can actually move tooth segments around. But we're widening and we're moving, the segments around to fit the teeth in. Because these cases have a high capacity to relapse. And these are Dmax appliances. So when do we start? We start whenever we see a functional problem. And we correct the parafunctional habits first. Ages 5 to 12 is kind of our window of opportunity. We capitalize on the growth plates. Okay? So why not fix something while they're still growing? Why wouldn't you do that? We can still use expansion through early 30s and into adulthood, although it takes a little longer, because we can open up those growth plates. But, the growth plates are like tectonic plates in the earth. You got subduction faults in California that move. These are the same, it's kind of like the same thing. So there you go. Okay? So now we're going to take, Ray, are we there yet? Oh, Danny. Okay. So Danny, bless her heart, she's not feeling so well, but and my staff isn't here because they all got the stomach flu. So Danny comes up to me and says, she's going to talk about gut function. She goes, but I think I'm getting the stomach flu. So I go, well, I'm not sure. But anyway, we have a lot of patients that come from Danny, and we're grateful for that. Danny's a fantastic nurse practitioner. She used to work with Dr. I'm sure many of you know her. She used to work with Dr. Gelb. She's gone out on her own now. And so we're going to have you come up, and I give you Danny, okay? You're welcome. Thank you.
I'm all right. Do we have it? Oh, yeah. Okay, so which? Okay, all right, thanks. Yeah, hang around, make sure I know. I have trifocals and something going on with my gut. It's really a good day. Thank you.